I am Dr. D. Silver, and I'm a neurologist and movement disorder specialist at Scripps Memorial Hospital in La Jolla, California. Now tonight, we're going to discuss essential tremor and its medical and surgical treatment. We'll discuss deep brain stimulation as a surgical treatment, and we'll discuss the procedure for essential tremor that is non-ablative. It does not destroy the brain tissue as compared to thalamotomy. So what are we going to talk about tonight? We're going to give an overview of essential tremor. First of all, we're going to talk about what is essential tremor. Secondly, we're going to talk about the clinical features of essential tremor, which are really two types of tremor. They're an action tremor and a postural tremor. Then we're going to talk about a differential diagnosis, because we want to know for sure we have the diagnosis correct, that of essential tremor. And then we're going to talk about the treatments of essential tremor, which are really of two types. They're medical and they're surgical. Now, we don't know exactly where essential tremor, pathophysiology, or anatomical abnormalities occur, but we think they're probably involved in the cerebellum, which is here in the posterior part of the brain, and these connections connect with the brainstem with the red nucleus and the olivary nucleus and form somewhat of a circuit or loop. Now, when we think about treating essential tremor with a surgical procedure, we put the electrodes in the thalamus, and the thalamus is shown in this picture, and this picture also shows the basal ganglia, the substantia nigra deep in the midbrain, and also the striatum or the basal ganglia that we talk about and its connections. Now, what is essential tremor? Essential tremor is the most common movement disorder that we have, and it's very progressive. Some people progress slow, some people have a more rapid progression. So the definition is a neurological disorder characterized by a very rhythmical, involuntary shaking of a part or parts of the body, usually more than one part. The most common tremor is seen in the hands and the fingers and the arms. 95% of the people that have essential tremor will have involvement of the arm and hands. But it also can be seen in the head. For example, there is a no tremor like this, and there's a head tremor such as this. It can occur in the voice in about 12% of the cases, and the tremor sounds like a vibrato, somewhat like this. Ah. That would be a tremor associated with voice. It can occur in the chin, it can occur in the tongue, sometimes the legs, and also the trunk. But rarely is it isolated, and it almost always involves the hands and the fingers and arms. Some people with essential tremor will have an impaired gait, especially some imbalance or difficulty walking heel to toe, or what we call tandem, and can have subclinical cognitive impairment. This has been now seen more in patients with essential tremor. Also, some will develop Parkinsonism, and that's where there is kind of this overlap between Parkinsonism and essential tremor. What are the two types of tremor that essential tremor has? First of all, there is the action or kinetic tremor. It's a tremor that occurs with a voluntary action, such as eating, drinking, or writing. For example, if a patient is drinking, an action tremor, but when they pick up the cup, they would put it to their mouth and they would have a tremor. Or they could have it with writing, and if you did a spiral, you'd see little rhythmical shakes in the spiral. It's usually 4 to 8 cycles per second. The amplitude is probably less than a centimeter. That's the action or kinetic tremor. Then there's the postural tremor. Now, a postural tremor occurs in positions when the body or parts of the body is held against gravity, such as the arms in front of the body. And it is an abduction-adduction tremor of the fingers, and usually a flexion or extension tremor of the hands. Rarely is this a tremor where there's a pronation-supination tremor, like the resting tremor of Parkinson's. However, there are some patients with essential tremor that will have a little bit of a resting tremor. This tremor is often picked up by doing spirals or doing spirals on a sheet, and you see those very, very significant little notches or shakes in the tremor and in the writing. It is usually not a micrographic kind of script that they see in Parkinson's. Now, essential tremor can affect anyone at any age. Young children, older age. Age is the greatest risk factor, however. And really, this is an individualized type of tremor. The age of onset, the severity of the tremor, body parts, response to therapy varies with each person and even within the families. 5% of people over 65 have essential tremor, and it affects all age groups, and it affects all ethnic groups. Now, this slide or cartoon shows us the annual incidence of essential tremor. The vertical bar is the number of patients per 100,000 that occurs in these age groups. And the horizontal bar is the age groups. And you can see, even at ages 0 to 9, there is some minimal patients that will have tremor. But it gets more as the patients get older. And you can see at about the age of about 40 to 49, maybe 10% per 100,000 will have it. But age is the greatest risk factor. So who's affected? Well, it's a very common disease. It's 10 times more common than Parkinson's, and age, again, is the greatest risk factor. Genetics play a very important role. It's probably autosomal dominant. 50 to 70% of the patients that have essential tremor will have a positive family history. But some people will not have a positive family history. There is some chromosome linkage that occurs in chromosome 2, 3, 5, and possibly 10. If you have a first-degree relative that has essential tremor, you're 5 times more likely to develop essential tremor than the normal population that doesn't have a relative with essential tremor. And if that relative has tremor onset before the age of 50, then you're 10 times more likely to develop essential tremor. Environmental factors are really not certain. Now, essential tremor really isn't life-threatening, but it does affect the patient. It doesn't affect the longevity or the lifespan. But patients notice that they have an impact on their social life, their professional life. It's emotionally a problem, and how it varies in the person, job, and age really is an individual issue. It can give disability. It can cause difficulty with writing, eating, drinking, and speaking. And most importantly, it can be very frustrating. It can be embarrassing. Some people have it so severe, they'll develop a social isolation. In many cases, essential tremor progresses over time, and it can be more severe and more of a problem, and it can involve more body parts. As the tremor is more prominent as the patient gets older, it's interesting that the frequency reduces and the amplitude of the tremor increases. Now, how is essential tremor diagnosed? Well, first of all, there's no marker, there's no confirmatory test. We have to rule out other causes of tremor. You have to do a good history, very careful examination, and you look for things such as the action tremor, when they would pour water from one cup to another, or do a spiral, looking for those little notches in the spiral. And also sometimes you can make a supportive diagnosis by having a patient with essential tremor take some alcohol, and the tremor will improve, especially on spiral drawings. But you must rule out thyroid disease, metabolic diseases, and you have to rule out a disease called Wilson's disease that involves copper metabolism. There's a new syndrome called Fragile X syndrome. Fragile X syndrome is involved in males. It's older. It has a significant family history. However, not all of the carriers have the symptoms, and tremor and ataxia is very common. Spinocerebellar ataxia syndrome is a degenerative process that involves gait and balance, can have tremor, and certain types of diseases like dystonias or Parkinson's disease or involuntary posturings, which can be seen with cervical dystonia or spastic torticollis, where there's head movement, can be associated with a tremor. You can also have tremor made worse by stress or fear. Medicines commonly make tremor, and they'll be seen in SSRIs or antidepressants, neuroleptics, lithium, Reglan, medicine for the stomach, medicines for breathing, steroids, and commonly Depakote. Post-traumatic tremor can occur when someone has a head injury. It usually occurs after loss of consciousness. Rarely peripheral trauma will give you tremor. Thyroid is one of the most common causes that we see. You always have to worry about people getting hypoglycemic, or the blood sugar would be low, or having excessive caffeine, or withdrawing from drugs or alcohol, or having too much alcohol. Other neurological disorders are also associated with tremor, but Parkinson's and atypical Parkinson's is really the most common. Now, is the patient that comes to me having essential tremor, or are they having Parkinson's disease? And that oftentimes is a very difficult diagnosis to differentiate. And how do we make that difference? Well, in essential tremor, the tremor is usually action, or it's postural. In Parkinson's, it's a resting tremor, hand at rest, and they have a pill-rolling tremor. The tremor for essential tremor is more rapid. It's not associated with rigidity and akinesia and slowness or gait difficulty, but it's oftentimes there's a positive family history. Now, it's interesting, at some of the new meetings that we've been seeing and some of the recent meetings with the Academy of Neurology, there are new tests they're investigating for making the diagnosis. None of them are 100%, none of them are markers, but they're looking at echoes of the substantia nigra, they're doing PET scanners, they're looking at the cerebellum, which interestingly shows maybe some abnormalities with some difficulty with excessive use of blood flow to the area. So what we're having here is some investigative studies, but really it is not confirmatory. So it's a diagnosis confirmed by history and physical exam. There's no definite cause. Autonomic phenomenon rarely occurs like in Parkinson's disease, and we have to think about here the genetic heterogeneity. That means these genetics that are involved in patients having essential tremor really have a different presentation in many of the people. Each child of a patient that has essential tremor will have a 50% chance of inheriting essential tremor. We really think now that the cerebellar rubo-olivocerebellar loop is really the area anatomically that has the most likely chance of being where the pathophysiology is. Now, we've talked about essential tremor, the various types. We've really gone into a number of important aspects. We've reviewed the concept here. It's a genetic phenomenon. We talked about the action tremor, which is a tremor that occurs with voluntary movement. We talked also, very importantly, about the postural tremor. Now, the latter part of this evening episode, I'm going to talk about treatment goals. And what are they? Why do we treat people aggressively with essential tremor? One, we want to reduce the severity of the tremor, the frequency and the amplitude. We want to improve daily functioning. We want to improve quality of life. And we want to improve the impact of the tremor on the patient's occupational issues and also their social activity, because this tremor can affect the occupation and social aspects. So what are the medicines we use? Well, we think about essential tremor treatment broken down into medications and also surgery. The medications are, first of all, propranolol or Inderal. This is a beta blocker. You start low, you go slow, 20 to 40 milligrams, and patients have the drug increased in its dose, and about only 50% of the patients will obtain some significant benefit. Primidone or Myceline can be started. It's a different drug. It's an anticonvulsant related to phenobarbital. You start low, you go slow, and again, about 50% improvement in the tremor, and not all patients will improve. The newest drug released for the treatment of essential tremor is topiramate or Topamax. Topamax is a drug which we use for seizures. And again, it gets about a 50% benefit. You go low and you go slow. Now here are 3 drugs. Sometimes we put them together as a treatment format. We rarely use benzodiazepines, but sometimes we'll try Klonopin. But some of these drugs can be addicting. Gabapentin or Neurontin can be tried, but the clinical trials have shown it's probably not of much benefit. And then there's Botox. Botox can be used injecting in some of the muscles in the arm, and that can reduce the tremor, but it is oftentimes fraught with side effects such as weakness. The second treatment format is surgery, and there are really 2 types of surgeries. There is the stimulation, called deep brain stimulation, or there is the ablation or destruction of the nerve cells in the area, and we do this in the thalamus, in the ventral intermediate nucleus of the thalamus. Now, oftentimes people get involved in alternative types of therapy, like acupuncture, hypnosis, massage. These are of very little benefit. They have a big placebo response, and oftentimes they really don't have a significant, long-lasting therapeutic benefit. Some people will try reduction of stress, such as biofeedback and behavioral therapy, but it's of little benefit. Sometimes occupational therapy is used, and we think of getting adaptive devices, such as weighted utensils, other kinds of plate guards that may help. But again, we think of therapeutic management with medicines or with surgery. So we talked about drugs like propranolol or Inderal, primidone or Myceline, or we talked about Topamax or topiramate. These drugs have some benefit. We oftentimes use them together. Most oftenly, we go low and slow. So why do we think about surgery? Well, we think about surgery because some people don't respond to medication, and the tremor is very disabling. So we think about putting that stimulator in the thalamus. So if the symptoms are severely disabling, if the medication do not provide adequate control, and that occurs, as I mentioned to you, not uncommonly. Most people only get about a 50 to 60% improvement in their symptoms, and not all patients really improve. Also, these medicines have side effects, and sometimes they're very intolerable. So we'll think about surgery. Now, the progression of the disease really can jeopardize a patient's quality of life, but oftentimes the job. So surgery is considered. So what are the surgical procedures and options? They really are of 2 types. Number 1 is some kind of lesion that takes place that occurs in the thalamus. We're directing all our surgical attention to the thalamus. The lesioning can be done in really 2 ways: a radiofrequency type of lesioning or a gamma knife stereotactic radiosurgery. Now, by and large, as time has gone on, we have done less and less thalamotomies because it is destructive. It causes loss of cells. And when you do it bilaterally, there is significant complications that can occur. So we are now doing more deep brain stimulation. Now, Scripps Memorial has a gamma knife center, and we have the opportunity to do gamma knife lesioning. And we usually would only do it in patients who have really high comorbidity, medically very ill, and we would do, in those cases, some type of lesioning with a gamma knife. Now let's talk about the surgical procedure I'm going to spend most of the time on, deep brain stimulation, called DBS. It occurs in the thalamus, in the ventral intermediate nucleus, or what we call, in the medical terminology, the VIM. We've done a fair number of these at Scripps Memorial. We're a large DBS center. I do the programming for most of these cases, and Dr. Cannot does the surgery. Now, DBS is a stereotactic surgical procedure that uses an implanted electrode placed through the skull, through a burr hole, into the thalamus. The electrode is connected to this pacemaker called an IPG that delivers an electrical current to the targeted nucleus in the brain. This is a picture of the frame that is helped to stereotactically locate the thalamus. And then Dr. Ott or another neurosurgeon will perform the procedure where they put the microelectrode down into the thalamus. And this is a picture of Dr. Ott where he is guiding the electrode down into the thalamus by using the coordinates. So a small electrode placed through the skull, through a burr hole, into the thalamus, and we have that electrode connected to a little pacemaker, a pulse generator under the skin, and that, when it's on, delivers a current to a targeted nucleus that we think desynchronizes that area and allows improvement of symptoms for the patient. For essential tremor, they improve the tremor, its amplitude, and its frequency. Later on, after the patient recovers, and they're usually in the hospital only one night, they get programming. And this is done by an MD or a trained assistant, and we program the patient. They need to be cooperative and knowledgeable, and we use 3 parameters: voltage, pulse width, rate or frequency. So the voltage is the amplitude. When you do this with the deep brain stimulation, you have an opportunity in most patients to reduce the tremor significantly. And in the North American study, it showed that you could reduce the tremor at 12 months in 69% of the patients. In a European study, it was even higher. And most of those patients will get at least 50% or 75% improvement in their tremor. The DBS in ventral intermediate nucleus for essential tremor is a complex process. And if you want to get more information about programming and other aspects, the pulse width, the parameters, the frequency, and the voltage, you can go on pdasd.org, and I've written several articles that would be important for that. So let's talk about the benefit. Now, what are the benefits? The activities of daily living are improved in patients who have the DBS in essential tremor in the thalamus. This is a slide that shows us the measurements of how we monitor patients that would have improvement or their impairment before the surgery. You can see drawing spirals, pouring water from a cup, bringing food to the mouth, liquid to the mouth, and handwriting. Pre-implantment scores are generally around 3, and the higher the number, the worse the patient is impaired, the more impairment there is. And you can see after 12 months, after an assessment after the DBS, it is significantly improved. Most of those values are about 1.5. Now, side effects can occur. We have to be fair and balanced. We've got to talk about side effects. And what are side effects that can occur with DBS in the thalamus? Well, you can get numbness and tingling. You can get some dysarthria, occurs more with patients who have it bilaterally. You can get a little imbalance. You can get some involuntary movements, gait disorder. And some of these things can occur, but many of them are minor. But there are side effects and symptoms that we do see. Now, one of the significant concerns is the device and surgery-related complications. And what are they? Well, they all run by and large less than 6%. So the patient may need to have the lead repositioned. They may have a stimulus that is not effective, and they may have to have some other procedure or more medication. The lead or the electrode may migrate into the brain and actually pull up a little, and about 3% may have intracranial hemorrhage, and about 2% or less or slightly more can have some infection. So we've talked about surgery. We've talked about what we're doing more now is a deep brain stimulation in the intermediate thalamus, nucleus, and what we're doing now is we're trying to use that. This series of programs has been funded by the generosity of the Bell Foundation in honor of Glenn W. Bell Jr., founder of Taco Bell, and by Elaine and David Darwin. Environmental factors. We're looking at ways to understand this better from an electrophysiological standpoint. There's some new imaging studies, and also we're looking at new drugs. There's some new anticonvulsants that may be of benefit that will be tested here and may come out in the future. And we're looking for the option to have new, improved surgical aspects. So tonight, we've really talked about a number of things involving essential tremor. Essential tremor. It is very common. It is genetically tied in very importantly. People have a positive family history. It can be progressive. Age is the greatest risk factor. Clinical features are really two types of tremor. There's the action tremor, which occurs with voluntary movement, usually with drinking or eating. And there's the postural tremor that occurs when you maintain a body part against gravity. That's usually in the hands. A few people can have resting tremor. Some of these people rarely will start to develop some minor Parkinsonism. Now, the differential diagnosis. I can't emphasize enough it's important to have the correct diagnosis. Rule out other diseases. Think of some of the new genetic disorders like the Fragile X syndrome. Make sure the patient doesn't have thyroid disease, and make sure medicine is not causing it. And then we talked about the treatment. The treatment falls into two categories, medical and surgical. I talked about Inderal, talked about Myceline, and I talked about Topamax. And we talked about surgery. We're mainly doing the DBS, and that has been, in my opinion, very successful. Well, it's been a fairly fast-paced program on DBS and essential tremor. I hope it's been informative. I hope we've had some enjoyment, and I hope it's been encouraging, because it is an encouraging field. I'm Dr. D. Silver, and thank you, and good night. This series of programs has been funded by the generosity of the Bell Foundation in honor of Glenn W. Bell, Jr., founder of Taco Bell, and by Elaine and David Darwin.